Hello everybody and welcome back to this lecture. The title of my lecture today will be the prosthetic rehabilitation. I would like to show you step-by-step procedure, clinical and lab procedure, in order to really fulfill the request of our patients and to be able to finalize your extensive rehabilitation in a proper way. So we try to give it to you a kind of predictable clinical approach. So let me introduce this guy. The name is Max, he's from Florence, and he came to my office in order to be visited to really fix his teeth. That was the request of my patient, fix my teeth. So I was looking at him talking, I couldn't see any teeth at all underneath. So I believe that it was without teeth, they needed denture. But it was not denture, it was actually a kind of attrition, very, very heavy attrition. Seemed to be a proximal activity, quite hard one, quite tough one. And actually that's the reason why you have the shortening of all teeth, upper and lower. If you look at the three pictures, in every situation the patient doesn't show teeth at all. So it's really a big aesthetic problem for him, because of course he cannot see the teeth during normal life. That is not good at all. So let me check with you. The space is there. Where the teeth are, they are lost on space actually. They are lost on space. Maybe they should be somewhere. Maybe it should be in this position here. Maybe not. Maybe in this position here, or maybe in this position. So how to decide where the incisal edge should be? Because remember, this one will represent the first step in every prosthetic case. The starting point of your evaluation, aesthetic and functional evaluation, starts from the position of the incisal edge. So, many steps you should really follow in order to know where the incisal edge should be. Starting from the two proportion, the two exposure at rest, the smile line of the patient, the anterior occlusal relationship between upper and lower anteriors, with overjet overbite ratio, the position of the mandible if it is in an acquired position or in CR, all the phonetic tests. So there are many steps that you should follow in order to be able to catch the real position of the incisal edge. So in the meantime, I said the rest position. Rest position is something very useful because, as you know, men at that age, on the 50s, should show maybe not 3 millimeters like a young woman, but at least 0.51 millimeter of central incisal edge at the rest position. But in this case, you are a -5. As you can understand from this here, you are -5. It means that you have up to there. Okay? So the incisal edge is 5 millimeter underneath the upper lip. So it means that you have no visibility of teeth, of course, at rest, but even during the normal speech, normal life. And also the lower arch are similar situation, still not visible at all, and very, very far away, incisal edge from the lower lip line. So we should rebuild the teeth in an incredible way in order to be visible during the normal life. So two exposure at rest on the upper and lower are -5 millimeter. So let me start with some phonetic tests. We have seen already the importance of the test, the phonetic test, like F sound, like S sound, and like E sound to determine the position of the incisal edge. Let me start with the F sound. And the patient seems to be really internally located. The incisal edge is far away from the vermilion on the wet part of the lower lip line. So theoretically, if we needed to put the teeth more out, that will be very possible. So we can minimize the preparation aggressiveness because we have to add volume externally, backally. And then the sound, as you know, is very important for two reasons: to determine the VDO and to check the VDO when you increase it, but that's not the case at this point yet. But other important role is if you have a retruded or anteriorized position when you say S sound, like 66, 67, or like Mississippi. As you can see from this S sound, seems to be quite vertical, so not going with the mandible more in front. So you can elongate the teeth without any problem. Okay, that is another important step. That was better explained, of course, in the chapter that was discussing about phonetics. And then we have the E sound. When you say E, prolonged E sound, you should see 50% of the incisal edge, 50% of the entire body of the lower and the upper. But you could see here, you cannot see, E doesn't see any teeth at all. Again, is the problem. So phonetically, all the tests say to you that you have to increase the volume of the teeth. Volume means not just the length, but also the body. The body was lost already. An enamel was lost there. So let me see. We have some incredible wear in this case. And this attrition phenomena in this particular situation. And attrition is equally common in maxillary and mandibular anterior teeth, starting from the anteriors. And then when you cut back all the cusps, all the incisors, the length is completely removed, the normal ideal length. At this point, you have the chance to see that it's still not working on posteriors, but at a certain point, once you have flattened completely the anteriors, you start to touch it to destroy also the posteriors. As you can see also from this picture, you have this kind of wear, this kind of attrition everywhere on posterior area except molars. Molars are not really affected so much. We have some bridges, some implants on lowers, on posterior area. You will see now from the X-ray. But actually the overall situation is quite complicated, as you can understand from this picture. So again, what about the position of the mandible? Position of the mandible is an acquired position. The occlusion of the patient is an acquired position, but it is not in centric relation position. So if you guide the patient back to the CR, not because the CR is on the back position, but because in this case the teeth and the mandible was going forward in anterior position, is anteriorly positioned. So we have to regain the most anterior superior position of the condyle into the glenoid fossa through the disc, doing the dorsal maneuver of the leaf gauge, and this position is a little bit retruded than the acquired position of the patient. So now we have to put, in this case, if you want to treat the case completely in CR, of course, increasing the VDO, because you have to highlight the new length of the teeth, because they are completely disappear. As you have seen in the previous slides, we have not the possibility to see any teeth at all. Another problem is the position of the cuspid and the lateral. We should understand if it's possible to do something in the proper way. It means if it's possible to have the chance to close the diastema or to do ortho before doing any pros. Of course, the ortho is always the first option, but many times the patient don't want to go to the orthodontic treatment before pros. In this case, we try to see if there is any chance to close the diastema anyway. You can see the lower arch. On the right side, we have a bridge. On the left side, we have 3 implants that are on posterior area. So we have to close the diastema, as we said. We try. Also on the upper anteriors is very visible from the closest view, the space that are quite big. It is not easy, but we believe that in some way, maybe preparing the teeth a little bit inside the sulcus, we can avoid to do any ortho if the patient doesn't allow us to do it, and finalize the case in some sufficient way. So severe anterior wear is shown very well in this picture, and also in this picture showing the smile and the very small teeth, the upper teeth, looking just smiling, or also highlighting the 6th anterior with the diastema. So very small teeth. But more than that, I would like to stress one point. We have a kind of recession there on the left central incisor, left lateral incisor on the upper arch. Recession that can be in some way fixed with some periodontal treatment, of course, that covering the roots. But the patient didn't want to do this because you have to wait after that, of course, for the soft tissue healing and maturation. You want to finalize the case immediately, if possible. So we can decide to do another option, to keep this kind of situation in place and to have the chance to finalize your preparations on the CEJ, not arriving up to the gingival outline. And because the smile line, if the low smile line, nobody will see. And that is another option. Of course, you have to explain in advance to the patient. You will, of course, wait more to finalize the case. If you do surgical procedure, you have to wait more, you have to pay more, of course, and you have to suffer a little bit more. Altogether, you have to understand if it's possible to do it, or it's better to do it or not. He decide not to do it, and to do maybe later on. So we have not take any risk to lose the teeth, to miss the teeth. So that's the reason why we can have the selection, or we can have a choice by the patient. So lower smile line, cervical recessions, we discussed. And now you see the X-rays. You see, we had the chance to see that, of course, we have a good periodontal support. That's very important everywhere. We have also the 3 implants very well integrated, and prosthetically speaking, with a very good result in terms of maintenance. Of course, we have other restorations, like this bridge that has to be substituted. And then we have to do all the restorations here, all design that you want, like tabletop on the buccal-occlusal veneers, 4 veneers on the lower arch. Plus, of course, on 3 implants, you can decide to remove everything and to do a new prosthetic stuff, or to keep the prosthetic stuff that was working very well for many, many years, and to cover with the new ceramic, because you have to increase the video so we can create space. Preparing minimally the ceramic work, then you can bond the ceramic to the ceramic. And that will be very challenging, but very nice. We do, sometimes it works very well. So that's the X-rays that shows all this stuff. Now, as we said, the first step should be that to increase the vertical dimension. And of course, you have to ask yourself, have you any concern about it? And the question that you have to ask yourself is it possible to change it? And what happens when increase it? And how to decide the amount of increase, and how to test the increase, in which way. And that's an important step. Let me check with you how is the height between the 2 arches from central to central incisor. It's like 12 millimeters, like that. We have no other idea if we had a different kind of video at the beginning, but we should measure basal bone to judge, not these points over there. So let me tell you, increasing the video is necessary 100% in this case. We cannot avoid to do it. And of course, many people can say, yeah, it is lost already, so we cannot have any problem if you increase the video because it was lost. But that is not true 100%. What it means? It means that when the teeth are still grinding together, so they are touching and grinding each other with the facets that are present there, could be a kind of a compensatory phenomena of bone apposition from the cementum of the roots that create a new bone and a kind of over-eruption of the teeth. So just to better understand, I would like to show you this picture that I was taken from the Dawson book, I believe, if I well remember. Anyway, it's interesting because you can see when the teeth reduce the height, like from this height between the upper and lower teeth to this one, upper lower teeth, you will see that they're much shorter. But at the same time, look at the A. A is the bone. The bone is increased the height. It was like that, and now it's like that. So there is a kind of compensatory phenomenon. It can be 100%, maybe sometimes not. As these authors say, if the eruption occur at the same rate as the tooth rate, the video remain unchanged. So it can be exactly the same. If not, of course, can decrease over time. So depending on the speed, how they grind, how they build up new bone. Okay, should be more or less possible. So that's interesting because if you have not lost the video at this point for this kind of a compensatory mechanism, what do? You want to add anyway? You want to increase anyway? Of course, yes. You have no other chance because clinically speaking, you cannot restore properly this teeth without increasing the video. So let me check. What we do at the beginning when you send all the information to dental technician. First of all, you should send aesthetic and functional information. And then you have to take the stone cast of the initial case, and then a face bow, and then 2 records at least. Occlusal registration in MI or CR, of course in CR if you want to rehabilitate the case because it's a complete new rehabilitation. So once you start to cut the teeth, being the maximum expansion or acquired position, a kind of a dental position, if you start to cut the teeth, if you start to grind teeth to put your restorations, your provisional, what you want. At this point, you have to find a new position. That position of the teeth were completely lost as soon as you start to work on teeth, to grind teeth on the two arches. So occlusal registration in CR, video increase have to be determined and sent to dental technician, and protrusive record, of course, in order to set a better way the condylar path inclination. That's allow our technician, better to say, to program the articulator. And then, of course, you can have the chance to create a kind of a lab chart, a static checklist, a lab chart to send to dental technician. So laboratory data sheet. And actually, we have the chance also to send the videos and picture. Picture is great. Video is much better because picture represents just a static moment of a dynamic action that can be catched only by videos or looking the patient in front of you. Last but not least, today, instead of using this, use the GetUp that we have already shown you. Is an application that we have developed and you can find in the Apple Store and under Fradiani Education or Fradiani name. So aesthetic analysis. We have started to do aesthetic analysis step by step. All parameters are described, they are understood. And then, of course, that's even more important, to do the lab chart, sending to dental technician all the aesthetic and functional information that they will need in order to really fulfill the request of our patient. These two charts are in the volume 1 and volume 2 of our book, 12th edition in starting from 204 to 207, 204 volume 1, 207 volume 2. So that's the cartel aesthetic, the aesthetic checklist of this patient, and the lab chart of this patient with all numbers. So we know that everything was put in, and the technician finally can find a way to really follow a kind of indication that the clinician gives to him, not inventing as they unfortunately many times need to do because they have not so many information in many cases from the clinician. Today, as I said already, we use the app, but at that time we have not used the app because it was not still in the market. So anyway, what you have to summarize, to have to collect all data. Again, store models, Facebook, and then CR record, protrusive record, and then all the data about what to do, how to modify with the static checklist, lab chart, and today GetUp the application. So in this way, what you see here are the WhatsApp derived from all the information that the technician received to do that. So from the beginning to the final WhatsApp, you see there is a huge difference. The huge difference is not obtained by chance, but is only obtained by looking all the parameters, aesthetic and functional parameters that we have seen together. And in this case, we have added so much volume that you have not touched the store model underneath, and we just apply more wax that completely cover the existing teeth. So if you want to do any kind of mock-up, you can do it, because mock-up, as you know, is a reversible kind of solution. You can print this wax-up directly in the mouth with the acrylic, bis acrylic, and you can have the mock-up done. And then you can remove it once you have tested, once you have approved, once you have shown to the patient, and you can decide if you go ahead or not going ahead. So, WhatsApp representing practically what? Representing, of course, the treatment plan that you, clinician, have already seen, looking all the aesthetic and functional parameters, as already said. So I want to see this kind of situation as and in the mock-up, to really mimic what I can do with my case, grinding the teeth, taking the impression, finalizing the case. That will be my goal, that to copy the WhatsApp that we have done. Of course, if the WhatsApp, once it is printed in the patient mouth, becoming mock-up, is really following all the instructions, all the characteristics, the feature that we believe should be created in this case. So let me show. We have put all the aesthetic and functional parameters inside. Now, the wax-up at first, the mock-up at second, and the temporary third, will become a prototype for the final restorations. We have started, better to say, our dental technicians started to build up the anterior sector as first step. Once you have received from the dental from the clinician all the information, how much to increase the video, how much to increase the length of the upper and the lower, at this point you create a space for posterior teeth. So first step will be always the determination of the incisal edge position. I could say positions because I'm talking about upper and lower, of course. And you see that we have elongated a bit the anterior teeth, and then we will create some more thickness, some more palatal thickness on the lingual part, on the palatal part. After we elongate this incisal edge, then we can have the chance to create some kind of thickness over here. Incisal edge position, that's the complete wax-up. You see the where that was present before, and now you see the full anatomy and wax with the upper jaw and with the lower jaw, closing the diastema. And I could say that Giancarlo Barducci, my technician, we've been working together for the last 40 years, unbelievable. He is really great on really changing the shape and creating better contour for restorations. So final wax-up was made. And now we have the stone model derived from the wax-up. And at this point, we have to really be sure that understood what we have to send to dental technician. So remember, what they want to know, how much you have to increase the length and the volume of the upper and lower anteriors. That will be the starting point. So creating the determination and creating, achieving the determination of the new incisal edge on the upper and the lower arch. That will be the starting point for sure. Then we have the third step, that is what? The orientation of occlusal plane, to be sure that the occlusal plane, starting from the incisal plane to the posteriors, will be the one that is perfect, parallel to the horizon. Okay? And then, of course, will be very important, the occlusal posterior stability in CR. We have to create an occlusion that see all the marked contact to be the equal intensity, synchronized with the very marked contact. It means that we will be very sure, really sure that we have a great contact on posteriors. Plus, of course, light contact on anteriors, but still present there to create anterior guidance. Or it means incisal and cuspid guidance in order to exclude all the posterior teeth and avoiding any kind of interferences. Last but not least, the increase of video, as we said already, that's his big point. You need to determine how much increase the video. All these steps are to be sent to our technician. And of course, they should receive this information, indication better to say, for dental technician. So they don't have to invent anything more. They don't have to become a magician to understand. They should just follow your instruction. So the increase the video in CR, again, we just covered all the stone models without touching there, so we are still possible to do a mock-up that, I repeat, is a reversible kind of condition. So initial stone model, final wax-up. And now we do the mock-up. We have to take an impression of the wax-up and the silicone matrix derived from this, from the stone model of the wax-up, so the ideal one. But remember, the wax-up was made not by chance, but just studying and going back to all these parameters, aesthetic and functional parameters. We put some bisacrylic inside, we printed, we stay for 4 or 5 minutes, and then we remove it. And once we remove it, you see the teeth that were so short before now are perfect length, about 11 millimeters, normal for the age of the patient. So now we go ahead with the lower, and of course we have to do the same like you did in the upper, other 5 minutes, and then you remove it. And then let me close the mouth. It seems to be perfect already. The patient didn't check yet, but look it. we try to avoid to use normally this kind of instrument. It should be used maybe in the mouth, but is the only one that can separate the better way the teeth. Among them, you can be a better separation, still without touching the teeth underneath, just on the resin, on the acrylic. Now we are working. The patient doesn't see what you're doing. His eyes shows you that he's not maybe sure what happened. Maybe it's good, maybe not. We don't know. But he didn't see yet himself. But actually, we did just some little modification on occlusion, very little, and that's what's done. The mock-up was practically perfect. And now the patient starts to see himself in the mirror, say, great, he love it. He love it. And now when he talk, finally can show the teeth upper, lower, and that is very, very good for him. It was very, very happy for that. But we had done nothing yet. We just did something that is not a treatment, is a pre-treatment, a preview of what we can become. So then we decided to go ahead with the work. We have increased in this particular case 6.3 millimeter anteriorly. That is not normal increase. Normal way is about 3.5, 4 millimeter in 90% of case. But in this case, he lost a lot of BDO, so we needed to increase quite a lot. But the patient didn't understand that it was increased so much. He didn't rely on nothing bad. There was not any kind of speaking problem that can happen sometimes with the S sound. But in this case, nothing. So it was really nice. So 18.3 millimeters from 12, we started with 12. We increased the length of the teeth, upper, lower. We are in perfect occlusion, so we are very good situation to finalize the case. Remember that we can increase the video in a very easy way, actually, and up to 5 millimeters seems to be a really safe and predictable procedure, according to this article by Abduo published in 2012, among more than 902 studies. And actually, the associate and sign symptoms were self-limiting with the tendency to resolve within a couple of weeks. That's just in case you have some symptoms. But even in our study, in our publication on the video, we had the same kind of results. So we have the chance to say that the sign and symptoms, just in case that they exist, a very low percentage of cases, they will go away in a while. So now we start to functionalize the occlusion perfectly. So you can see here, we have checked the occlusion very well on the static and dynamic actions. It means on CR position with the red sign, very marked and regular marked sign on occlusion, and the anterior guidance. It means cuspid and incisor guidance. So that is the mock-up in place. Still, you see the short mock-up on the incisal area, on the cervical area, on the first central incisor, left and left lateral incisor. They were short for the reason we know, that we have a recession that you don't want to cover. So big difference on the smile of the patient, big difference also on the behavior of the patient at this point. So let me check what you've done. We did this kind of control of the occlusion. We maybe had some little slide still, but at this point there was nothing more. This is perfect. So actually we check it a better way. Now we let the patient close itself because it's one position only. We have the chance to improve this kind of finalization of the occlusal step. We try to grind the proper way to leave it just on the vertex of the cusp, the contact, and to have the chance to optimize so the contact everywhere, to have the Artus foil that is catched by the occlusion. Artus foil is just 6 microns. We still optimize 100%. We want to be perfect. So light contact anteriors, and now we ask the patient to move and to check if we have any contact on posterior, interferences at this point, or not. And we have a great result at the end. So we can leave the patient like that. It'd be great. So he can move right and left easily. The patient is absolutely in condition to move completely everything. So now we have the mock-up perfectly in place. Why we did it? Because this mock-up became for me the final work already. And now I can work cutting back this with my preparation, cutting back this mock-up and starting to take the final impression. So let me start. First of all, once I saw the patient moving so rapidly in a very easy way, right and left and in front, I can say, okay, I want to copy this kind of situation, this kind of movement of the mandible, anteriorly and laterally. I want to do a customized anterior guidance, and that's what I did. So, first of all, I take a bite record on CR. The question could be, why you take a bite record in CR if you are already in CR with your mock-up? Because, of course, I did all my occlusion in CR, as you can understand. I take anyway a walks-up, a bite record on CR for one simple reason. Because in the mouth of the patient, you have also the condyle, and is also stabilized by the occlusion, but also by the condyle position in CR. But once you take two impressions on the upper and the lower, and you have to mount the two models without any help, you can find a perfect position, but you can find also a position that is a little bit not the same one. It's exactly what happened when you take two initial models of a patient. You know, sometimes you have perfect, the occlusion is perfect visible, but some cases are not perfect. So if you take the bite record anyway, you can be sure that the CR position that in which the mock-up is will be reproduced also by the wax. So it can be possible to have some little difference. In this case, you can have the possibility to really understand that that is the position, because it is repeated by the bite record done by wax in this case. You see that is the bite record. I guide the patient in CR with the dorsal maneuver. It will be easy because now the mandible is working well, is moving well. There is no any kind of restraint. So that's the CR position of the wax. Then I use a water spray, remove it. And then they ask the patient to go edge to edge, to see the protruding record. It means how much space you open on the posterior to really have the chance to optimize then the height of the cusps, etc., etc. So you want to, of course, avoid any kind of interferences, but at the same time you want to achieve a nice condylar pipe inclination. Facebook taking, you could be put in front of the patient. You have also a level, as you could see here, is a level over here, okay, to be horizontal 100%. So, and then you take the impressions of the mock-up. Mock-up in the upper, mock-up in the lower. And then you have the perfect situation in the mouth of the patient. The patient was having perfect occlusion, perfect aesthetic and a functional result. So that is why we want to copy 100%. We are still in the mock-up, repeating. So upper, lower, we want to copy. We want to copy. Exactly. We want to copy 100%. Now, I had the chance to do this kind of Facebook taking, the two provisional, the anterior guidance that we have already optimized the mouth of the patient. You can repeat, you can replicate, you can copy on the final work. So at this point, you can create this kind of situation here. You remove the metallic appliance that you normally have in this situation in the pin. You remove it, the average one, and we put two little pins, and then you start to use a kind of resin that can be self-curing or also light curing. You move from CR to all the eccentric movement, the two stone models, and once you are finalized everything, you can start to use the light cure and moving the pin right, left, and in front. So mimicking all these movements that the patient had in the mouth with the mock-up, it was working well. So that's the reason why we want to copy. And then you arrive to the pin, to the initial situation. And once you are done, we use the little pin that we put in the base before, and you remove this customized anterior guidance. And at this point, you will put in the box of the patient, and that will be forever. So this kind of anterior guidance is what the patient had already optimized tested, proved, and adapted 100%. And once you do that, you have to need to copy to have the replica in your box in order to be able then, when you build up the final restorations, to be able to repeat it and to copy 100%. Now we can copy all the position of the mock-up already, on the upper, the lower, on anteriors, on posteriors. You have the chance to use the silicone index again, derived from the wax-up and derived finally from the mock-up, that is practically the copy of the wax-up, with some light minor modification we made, just minor. So that is all the set that you can do in a buccal way, a crucial way, to copy exactly what you have done. And then you can divide into parts. As you see, you can check it, and you can really repeat the same position. I don't want to say copy, because then you can improve. Of course, you can use ceramic work the proper way, and you can have then the chance to do the cross-mounting procedure that has to be done at the same mandibular position, it means CR, and at the same height between the two arches, it means at the same VDO. So you can take registration, bite registration, at the same height, at the same CR position. And then you can replicate what you have done. So, but in this particular case, we started with preparation of posteriors. So we have done the mock-up. Okay, we have mock-up ready. And the mock-up has to start to be cutted back. So the patient is from Florence, as I said. We put the mock-up. We left the mock-up in place for 2-3 weeks. And after 2-3 weeks, we started to do a posterior areas, keeping the anterior in place. So we keep the mock-up of anteriors in place, and we start to prepare the posterior teeth only to be finalized. In the meantime, we will have, at the end of the first phase, all the tooth prepared on posteriors, and then the restorations finalized on posterior, keeping the anterior relationship in mock-up, still in mock-up. So as you can see here, we are prepared with a calibrated reduction, and we kept the anteriors unprepared. So we kept the position of the anteriors. We kept the posteriors. So VDO and CR were maintained through the occlusion stability on anteriors. That is perfect. Goes easily to the CR and maintaining the VDO. The preparation on posterior were really ridiculous preparation. What it means, we didn't touch on anything practically. We just kept the enamel, we just refined a tiny bit, but we kept the enamel that was still present there. There was not so much enamel, but anyway, in this case it's quite a lot actually, but not so favorable in every teeth. But the enamel that was present was kept 100%, because of course we have already some lost volume of teeth and enamel. So we want to keep the enamel that was still there to be bonded. So we have removed the restoration on the back side. In this case, we have to recreate a new bridge, preparing the teeth, preparing the new bridge. In this case, a crown over here, and then you have the 3 implants that we have just prepared slightly. We will see later on. So once you prepare back with the normal thickness, with the calibrated reduction, taking into account the fact that we need to know what kind of material that we select after that. So if you want to keep a material that is able to have 5/10 of millimeter or 8/10 of millimeter or 1 millimeter, according to that, once you cut back and you remove the mock-up, you see that the teeth were not touched at all. So it means that we have not touched the teeth, means that we can really save all the enamel that is still present there. And then you have to communicate to the lab on posteriors. We take 4 impressions. Why 4? Is not enough to have 2 impressions? Maybe yes. But what is the meaning? Why I should stay on 2 impressions and not 4? What happens if I take 4? I take 4, I take maybe 10 more minutes to take other 2 impressions, but actually you have much more information maybe. Maybe. I don't see the first impression, I don't check it, I just remove it from the mouth, the first impression. I don't see the impression itself. I put in a place outside my view, and I take another one. And then probably the first one is still better than the second one, but you never know. But in 5 more minutes, you can have much more information sometimes. So that's why I take a double impression, not just one, but 2. And then all the byte records, etc., etc. All the communication, the CR record, the Facebook, and the byte record that we needed. Let me check on posteriors. Final impression of upper and lower posterior teeth. Okay? Because we kept the anteriors in place with the mock-up, still with the mock-up. Facebook taking, CR record, protrusive record, as you have seen already before, a byte records of upper and lower preps. But of course, that is upper lower preps against the mock-up. And we see in a while what do we mean for that. And then, once you do the byte record of the upper lower preps against one arch, maybe have the preparation, the other arch you have the mock-up, and then the opposite, and then preparation against preparation. There are 3 different byte records that you can take it. Now we see. It does allow you to go ahead for the cross-mounting procedure that allow you to really copy exactly what you have done on the mock-up that you like it, that you love it. So cross-mounting, you have in this case mock-up still present on posteriors, upper, you see, and lower arch preparation. That is 1 byte record. To do the cross-mounting, you need at least 2, because you have to divide the space between upper and lower. So we can do the same one. Preparation now in the upper, and mock-up in the lower, so the opposite. That's the second byte record. Preparation in the upper, and mock-up in the lower. But sometimes, to remove the mock-up, you can break it. So at least 1 remain absolutely normal, not broken, but the second one can be broken. So if you have these 2 byte record, is already enough. So that's the second byte record. And this one is the third byte record between preparation upper, preparation the lower. Some people many times ask me, is not sufficient to have one like that between the 2 preparations? Not if you want to copy the occlusal setup that we have done on mock-up and the speed curve, etc., etc. So you need to know how to divide the space between the upper posterior arch and the lower posterior arch, because it can be occupied 50% and 50% or 70% and 30%. So how you can know? Just having copied the mock-up that you have done before. So if you take one of the 2 records that you have seen before, that is this one, for example, so you can cut only the upper and then take the byte record between the upper preparation and the lower arch. And then this one. So with the 2 of the 3 byte record that you have seen, with the 2 of them, you're already enough to have the cross-mounting procedure. So taking into consideration all this, and that's the way how we do it. So now we have the full space between upper and lower, because at this point we have the chance to create a lot of space between the 2 arches, having increased 6.3 millimeters, and we don't need to, of course, to cut the teeth occlusal at all. We have still enamel, as you could see here, on the incisal part, on the cervical too, and occlusion. If you had enamel before, the enamel that you added, you kept, of course. But it was unfortunately not enamel 100%, it was just partially. Okay, so third byte record. So 2 of them are already good. So preparation with mock-up can be upper or lower, or the other one is one of the 2 that we have seen. But 1 mock-up has to be maintained to take the byte record with the preparation. Can be the lower, can be the upper, it's the same. And the other one with prep against prep. And that will be easy. So 2 of them allow you to do the cross-mounting procedure. This one is the last one that you have seen, prep against prep. And this way, we have the chance to finalize the case following, again, all the occlusal setup in terms of position of the posterior teeth that we had before. That was with the mock-up in this case, that we have tested very well in the patient mouth, and we copy on the final one. Not exceeding in any place, just staying there, the same position, as you can see. The silicone matrix is derived, of course, from the mock-up. So, upper arch and lower arch, we are almost finished. We can see that we have maintained the occlusion also on the lingual part, palatal part of the upper. In 3-4 weeks, nothing happens, of course, can stay easily. So we are able now to finalize the case on the upper arch, posteriorly, of course, and the lower arch. And you can see here is a new bridge that we did it. The case was done in lithium disilicate, the bridge was done in zirconia, cubic zirconia. And here we have prepared slightly the 3 implants because they were perfectly integrated. We just cut back a little bit and roughening all this area, and then we can cement it over ceramic. Lingual part, bridge and buccal occlusal veneers, bridge and buccal occlusal veneers. That's the lower arch, all the ceramic work between lithium disilicate in this case, and with the bridge we did again zirconia material. Lower, sorry, there is a kind of mistake over here. Is palatal view, yes, sorry, palatal view. All the in terms of finalizing with the bonding procedure, all the upper buccal occlusal veneers. Now we want to prepare the anteriors. Once the case was delivery on posteriors, now we are ready to finalize the anteriors. We start to calibrate tooth reduction, again with the thickness that we are able to then repeat with the final work. But once you check and you have removed all the mock-up, you see that the teeth underneath were practically untouched buccally, and they were shorting, 5 millimeters shorter than the preview final outcome, as you have seen before. So we have to increase the length of half height, half length. So we have untouched tooth structure there, but of course we cannot really grind even more. It's just to refine it tiny bit to keep as much enamel as possible and to try to bond the restoration the proper way. Calibrate tooth reduction, we close the diastema between the 2 central incisors. They are very, very short, as you could see here. And now we have to finalize the case. So another important step is, as you see in the protocol on the extensive rehabilitation, the systematic approach, the biological integration. And of course, when you talk about the biological integration, we refer all the time to the gingiva outline. And that's interesting. It's important, of course. Of course, we want to have a really minimal aggressiveness of our burrs inside the sulcus if you want to cover and hide your restoration. But when you talk about biological integration, like in this case, I want to talk about another step. I wanted to talk about this. It means when you increase the VDO, because you have lost a lot of volume of the teeth, to recreate a new occlusion, a new height, you will find a lot of space. In this case, you have a kind of preservation of tooth structure, incredibly, and you can do a mock-up that is 100% additive, and of course, once the mock-up is done, and we scatter back, and then you can have your final restoration, that is having 100% of additive solution on the remaining abutments. So we can refine preparation, but you cannot grind in the regular way. You cannot prepare the teeth. The term preparing is something that does not really fit perfectly. In this case, we are refining the teeth with a light, very light tooth preparation. and you have a lot of space available, so you don't have to cut. You can keep all the enamel that was present before. So we did that also on anteriors, not just on posteriors. And on anteriors, we kept exactly the enamel that was present there. There was not an incredible amount, but still a good amount present. You will see. Then we have prepared not to the cervical area on the 21 and 22. And what happened also? Because we have increased the vertical dimension of occlusion, we have a lot of space on anterior area. So we have not any need to cover, better to say, to prepare grinding, as I normally believe, to grind the lingual part of the upper teeth, because they have a lot of space. You have elongated the lowers, but we have also increased the palatal part of the upper teeth. And that is something that allows you to keep all the enamel that was present there. So 4 veneers were created, in this case, because it's an extended veneers that are covering all the lingual part for functional reasons. They want to have a contact between upper and lower. But it's untouched enamel in this way. So it's like a crown design, but with the heart that is completely different. It's a veneer extended to the palatal, of where you can find the untouched enamel, and you can have the complete restoration without having touched the lingual. So you can understand that backally you have enamel everywhere on the back side, except this area where you have a dentin already, as we said before. You see the second chord is not put inside because we don't need to arrive to the gingival line. We will maintain our margin supragingival on this and this tooth, both of them. So, enamel preservation, you see, the whitish appearance over here allow you to say that we have enamel 100%. We have also enamel here, some dentin in the middle, but a lot of enamel still present there. You can see that. So we have a very reliable final outcome. So we kept the margin there, and we kept enamel there. Biological integration is achieved. You can see the soft tissue conditions seem to be almost perfect. And now we're ready. We can take the par impression of the upper and lower anterior arch. So upper and lower arch anteriorly, upper and lower anteriors. Again, 4 impressions, not 2. And then we build up the temporaries. Temporaries with the MIT technique is well described in the 2nd volume of our book. It means that we have a kind of increased length and width. I will show you. The technician has to open completely the inner part of the shell if you use the methacrylate classic material. You have the chance to see that very, very thin, trying to mimic how much you will really be able to prepare in your teeth when you do this kind of minimal invasive prosthetic procedure. So here's acrylic provisional restoration with the MIT technique. I want to explain to you rapidly, if you don't know the technique, how you do it, because many times when you use acrylic shell to be relying in the patient mouth, you have the chance to see that the patient will have a problem. I mean, not the patient, the dentist will have a problem in inserting a large case like this, like an upper arch. Why? Because the contraction of the acrylic, it happens that you're not able to really put your shell completely in. That's the problem. So you start to open the hole again. You start to open the inside part to try to be able to fit it, but it's very complicated. You start to open some holes. You start to re-prepare the teeth. The patient will complain because they maybe have no more anesthesia in the classic traditional way of the preparation. So it's something that maybe you have experienced once at least, that will be very complicated to insert completely the shell before aligning. And that is a big problem. But to avoid this problem, you should change it something. It means you can still keep the same middle and incisal third volume, but enlarge the volume on the cervical third, having the chance to sign a kind of line 1 millimeter more apical. At this point, once you then put your wax in place, you will have the chance to have an elongated wax up. cervically is elongated. But at the same time, being this first part of the gingiva on the cervical area a little bit convex, you will be longer and larger. So the cervical third will be not perfect, will be a little bit larger and longer. But that's allow you to have a perfect kind of insertion of your restoration in place, of your shell inside the abutment, perfectly fitting, because it doesn't really create any friction on the cervical area. Will be free to move because they are longer, as I said, and larger automatically. So, more or less what happened is like that. We will have your margin inside the shell, because you will not friction in any place. We will not have a problem to insert it, maybe to be inclined in one side. In this case, it will be very easy. It will be guided by the occlusion. And then also you don't have to push your finger to let you give your impression on the relining material. You don't need it. You can remove it because all the margin will be inside, not outside. So you don't need to do it. Your maneuver will be much easier because you will go in subtraction, not in addition. At the end, with this MIT technique, we have a lot of advantages. First one is the easy provisional insertion and intraoral positioning. That's the most important step. You don't want to vanify what you have obtained with the workshop. We had invested time to help the technician to do the perfect workshop that is reproducing your treatment plan, and we wanted to have the reproduction on mock-up, but of course also on provisional, because then the provisional has to be sometimes copied to the final. In our case, in this patient, we had mock-up still in place, great, but can be provisional, can be what you want. The way and the moment you want to copy something working can be either the mock-up or provisional. If the mock-up was not perfect and then you modify something, the provisional now is perfect, you copy the provisional, not the mock-up. So in any way, if you have something to be copied, reproduced, at this point it can be the mock-up or the provisional. In this case, the provisional insertion has to be facilitated in order to have the same position of the workshop. And that's again, with the MIT technique, you can have an easy provisional insertion and easy intraoral positioning. With a minimal occlusal adjustment, and the occlusal adjustment shouldn't be done because you are guided by the occlusion, normally, 100%. You can easily remove the excess. You can have an ideal penetration of the relining material into the sulcus, acting more or less in the same manner of impressions with a heavy and light body. The heavy body, of course, is pushing the light body inside the sulcus. Why? Because you have a customized tray, and the customized tray normally is larger and a little bit longer, right? And then you have the heavy body pressing the light body inside the sulcus. Same mechanism, more or less, is here, in which you have the ideal penetration through the relining material that is put inside the shell that is pushing this material against the gingiva and into the sulcus. And at this point, defining the perfect way, the margin. Excellent marginal identification. Great. Easy and fast refining procedure without having the chance to have added with the finger around it and then to cut back. Then can jump away a piece, that is big mess sometimes. So, now you see the technique. You see, extending half to 1 millimeter more apically. So that's the way how Giancarlo did it, how give to me this kind of provisional, ready to be relied in the patient mouth. Provisional in place. At the time of insertion, we have shortened the left and lateral central incisors, lateral incisors. You see some irritation of the soft tissue, that is normal because you have taken maybe the impressions, but look, 2 weeks later, perfectly harmonized. Why? Because we have taken care about the marginal fidelity with our burrs, with our experience, still keeping our margins in the lateral and central incisor left side far away from the margins, but you see that all the other margins are perfectly integrated biologically. So biological integration not just is, but also, as I've said before, the quantity of enamel that you are keeping in place without cutting and grinding back so much. So once you increase the BDO, remember you have a lot of space, you don't have to prepare as normal way, conventionally, but in an innovative way. So the biological integration is a combination between this situation in which you save the two structure, preparing nothing practically, and of course, the perfect integration of the gingival outline. So now, provisional, in place, well integrated also aesthetically. Big difference between before and after. And now the patient is starting from that, change completely his mood, different, showing teeth in a perfect way. At this point, impression on anteriors, and all the bite records, plus the Facebook taking. So again, at this point, impressions of the upper lower anterior teeth, different than before that was posteriors. Facebook, CR, protrusive record, and then bite record of upper lower anterior preps. We see again. And then cross-mounting to copy exactly what you obtained on the mock-up. Yes, because the space here is easily understood, but you have to understand how to occupy the upper, how to occupy the lower, how much elongate the lower, how much elongate the upper, how much elongate the lower, how much increase the palatal part of the upper, how to divide from upper, lower anteriors. You have to copy what happened on the mock-up. So we can take the mock-up of the temporary or the temporaries in place, and we know how much to elongate it, because then you touch the upper provisionals. So you can divide according to the provisions that were already made and finalized before. After the mock-up, we prepare the teeth, we put the provisionals, and we can have the chance now to see how much we have elongated the lower and how much have increased the palatal part of the upper. So we interchange the models. You interchange the model, temp against prep, prep against temp, and prep, the three bite records, as you have seen before on the upper jaw. Then we are ready to finalize the case. The technicians are making perfect work on anteriors. You see that we have a kind of concavity on the back side. It means that we use a lithium disilicate in monolithic way, not layered posteriorly, lingually. That will be monolithic only, but backally, we can really leave some space for layering process to improve the aesthetic result. That is why it's concave. We have the pressing technique. In this case, we press this restoration, upper and lower anteriors. We can use different kind of material, multi, 1, A2, A3. We can take the natural dye material, the color of the abutment underneath, to have the chance that the technician can work on similar abutments, the same color, so to better mimic the real situation of the patient. Again, that's the concavity that I explained to you already. Look, the back side, incisally, you have a concavity. Incisally, you have a concavity in order to leave some space for layering. Keeping the vitality, keeping the monolithic material on the lingual, also in the lower, you have some space for layering process, as you could see here from this picture. And then the layering process takes you, or gives to you the opportunity to create some color, internal layering, internal characterizations. And of course, that is made by Giancarlo Barducci, as I said, ready to put in the oven. Final outcome in terms of colors, upper, lingual part, buccal part. On the very short teeth like that, could be useful to really create not a veneers on the lowers, but a kind of full veneer. We want to keep the preparation until the enamel and cement enamel junction. Then you have a recession over there, so we didn't follow the preparation up to this area, but just where the enamel was ended. but we can cover it with very short teeth. Remember, it has like 4 or 5 millimeter length, it should become 9 millimeter. So actually, that's the reason why we decided to cover partially also the lingual part with the full veneer. Upper teeth, final glaze, lower teeth, final glaze either. Final glaze on the upper, final glaze on the lower, lingual and palatal part. So, upper, lowers, anteriors, in place. All the pressing technique were used, and now, once you set the posterior, now you set the anteriors. All the restoration in place, and you can understand the length is up to here, the length of the abutment, but then you have unsupported porcelain. Look, you can see from the shadow. The cervical part and the middle part is in shadow, and then you have light going through, because you have the abutment, the stone abutment that is not, doesn't allow you to have the crossing of the light. But the sidal part and the middle part, you see that is half of tooth that was unsupported, unfortunately. But that was the situation, like in the lower and the upper, both. Is a risky case? Of course it's risky. All the time it's risky. But you have to do your best. So that is why what you've done is to create this kind of situation. This is exactly the abutment, shortening. We try to thicken it, the external part and internal part in monolithic way. We just left some space for layering there. It's up to you. You can also have less risk going just monolithic and just coloring over. It could be a good idea too, to avoid any kind of chipping. Again, look, you have the chance to see the CEJ. Even though you see the cord doesn't represent any problem because we are supragingival located. So even though you have the cord there, that is not on the margin, it's on the gingival margin, but it's not in our margin. Our margin is supragingival as CEJ. And again, enamel preservation. So we started with that in terms of length. Take a look, the transformation. That would be the final length. Of course, it can be risky, but you have to check the occlusion properly, and you have the chance probably to keep it to achieve good result. At least we have not long-term result yet in this case. You have short, medium term, up to 5 years. And I show you 5 years after. I said before, Giancarlo is great in moving and changing contour and the position of the teeth. Look, in this case, it was very complicated, but he did a great job. And that is the final outcome. On the lower arch, closing the diastema, before and after. That is the initial case on the occlusal view, the final view. Initial and the final. That's the time of delivery. We increased 6.3 millimeter the VDO. We left these two parts uncovered. And we closed the diastemas. Space management was perfectly managed by dental technicians, but also by the clinicians. If you see there is no inflammation, no irritation at all, upper, right, and left, we moved, of course, the long axis of the cuspid and the lateral and the central in order to be able to really match the situation. Beginning situation, lateral view, a final situation of the diastema that were completely closed. Final X-rays, showing a very good result and no problems, of course, even implants are remaining perfectly the same. That's the initial FM full mouth X-rays, and the final one to see the difference between before and after. But look at this. What happened there? Let me show you. A piece of cement over there. Very delicate. Now I want to tell you the story. We try to do our full mouth X-rays not the same day of the cementation. We try to do that after 1 or 2 weeks if we can, if the patient doesn't come from very far away. Anyway, we don't do it the same day because it's easy to leave some pieces of a cement excess inside. So normally it's capable to see 2 weeks later that you have a piece like that, so you do the X-rays and then you can remove it with the help of X-rays. Without, it will be very complicated to see maybe sometime. Even though because the floss was passing, but seemed to be quite okay, but was not okay. So X-ray, final X-rays are really showing something that may be clinically not visible 100% of the cases. So it'll be very important, very careful. Don't miss this point. After a couple of weeks, check the patient again, occlusally, and also for the cement excess removal. That's a very important step. Cement excess. So from mock-up to final. The next picture I will show you is the best picture I can show you. The best one. Why? Because it's incredible what you can really plan in advance. This is the mock-up that we made, the beginning, okay? That was before we starting any kind of work. It's just a preview without touching any teeth, just printing over 100%. But as I said, the mock-up and the result that we have achieved with the mock-up was not obtained by chance, was obtained looking all the aesthetic and functional parameters, checking all them. So we are so happy about what we had as a result with the mock-up. That means we have not started yet any kind of work. So I was so happy with the mock-up that we want to copy to the final. Because we have really studied the case in a proper way. The treatment plan was well done. That's the reason why we would like to copy. And the question now is, all the steps that we have seen are able to let us to copy this mock-up to the final? And the answer is in the next picture. Take a look. Position of the teeth are identical. But, do again, we just changed the material. Look, identical length, identical position, all identical. So we have, with the mock-up, already ended, already finished the work that in the real case you never started. You have not started yet, but you have finished already. You have not started to do any kind of grinding procedure on teeth. You have already finished your case, because if you have replicated your case to the final, means that you are more than happy, the patient too. So means that everything was working well. That to say to you that we can really replicate something that you like it. And then final outcome in the function, before and after at the rest position, before and after on the smile of the patient, lateral smile, lateral view. 5 years later, still, recession is still there, of course. He didn't add any kind of surgery yet. In protrusion, everything works well. All the soft tissue are getting better and better. Cuspid guidance one side, other side. So seem to be perfectly adapted to the new occlusion, to the new length, to the new volume, to the new aesthetic result. With the canine guidance, right and left. And that is how the patient moves, frontally. Of course, we want to have always cuspid guidance right, cuspid guidance on the left, and anterior guidance. So, I believe that we have the chance to see how to treat a case that is a complicated case. That was a Braxian activity, it was a complicated case. And I believe that the most important step is really to plan perfectly in advance what you should do. Through the aesthetic and functional parameters, you are able to really optimize your work-up, so automatically your mock-up. And once you have optimized your mock-up, you can really copy through all these steps, clinical steps that you have seen, to the final work until the end. And having the chance to really compare the initial to the final that is identical. I hope that you enjoyed this lecture, and I'm sure that we will see each other next. Bye.